So welcome back, everybody. Hope you really enjoyed your workshops and found those to be hugely valuable. And thank you for those of you who have come back on time and already are raring to go. And for those of you who weren't here earlier, I'm Caroline from NHS Select, and it's our pleasure and privilege to be supporting today. But really all we're doing is kind of doing the Q&A and just making sure the tech works and things. So and without further ado, I will hand you over to Jennifer. And thank you, Jennifer, so much for joining us. As I was saying as we were sort of warming up, we've had lots of questions about community services and using the SD model outside of acute. So I think there'll be a lot of interest, and it's a very lively group with lots of questions, really curious group of people online. So I'm looking forward to a fantastic hour together. You've kindly agreed that you will stop, you'll pause, you'll take questions. So I don't think I need to encourage people, but if you would like to pop some questions for Jennifer in the chat, please do. If you've got anything to share that you think this is my experience around this, pop that in the chat as well. The more interaction we have, the better, I think, Jennifer. So I know you agree with that. So we will hand over to you and look forward to this immensely. Thank you.
Oh, thank you, Caroline. I'm conscious that I've got after lunch, so hopefully people have managed to stick their heads outside or get a little bit of fresh air if you've got your lunch. Hopefully I won't distract you too much from it. I'm sharing my slides through PowerPoint Live. I'm conscious that you can all have a good old scroll through them and a little nosy, so feel free to do that. I'm not going to take that personally if you end up focusing in on some different slides. I'm not going to be going through the full pack, but I will make the slides available afterwards. So if there's things in there, you will be able to sort of look at them in a bit more detail. But a huge thank you to Vanessa for reaching out and inviting me along to be part of this. So really exciting to be part of an NHS England event, because of course I'm NHS Wales. So my name's Jenny Morgan. I work in NHS Wales, and obviously you all know that health is devolved in Wales. So I'm going to use some slightly different terminology to you guys, but you know, we all know that there's lots that we can learn from each other. So hopefully there's some real commonality. I'm aware that Stacey and Douglas were also talking about domiciliary support. So again, I think there's so many overlaps between everyone's presentations today. So I'm going to be talking to you about right sizing community services. So this was us taking a system dynamics approach to help planning for delivering for the whole population of Wales. So this was a joint effort, a number of people involved, and so I will name check them as we go through. I do like to do the spoilers at the beginning, though. I got taught quite old school when it comes to presentations of tell them what you're going to tell them, and then tell them again. So no surprises here. This is what I'm going to be talking about here. And it's that I'm really passionate about the fact that big, complex, bit of a contentious word, complex. Is it complex or complicated? But big systems require that systems thinking. And I strongly advocate that there's a lot to be learned from archetypes and existing models. So what you've been hearing today are lots of existing models that are out there, and there's lots that you can gain from that. It's all about the requisite detail, a beautiful system dynamics phrase. What do we mean? How much is enough? How much detail is enough and no more? We don't want to be going into lots and lots of detail if we don't need to. It's not always about what does happen, but what should happen. So that's actually a bit of a theme of the modelling work that I'm presenting today. We were interested in specifically trying to explore what should be happening and how might we get there. It's also about socializing this idea of a dynamic hypothesis. So what do I mean by that? I literally mean graphs over time. I love a graph over time. We've seen loads of them so far today, haven't we? But that's a really key element here, is we're interested in seeing that graph over time rather than just saying what the current status of something is. We want to see what its history looks like, what its variation looks like over time, and hopefully we can get some of those projections like Peter was talking about earlier this morning. And I also strongly believe it's system dynamics is very much part of the analytical toolkit. So it's not necessarily about us having people who just work on system dynamics. I think that we can have analysts, modelers, improvement managers, operational managers, planners, all being involved in this with varying levels of expertise in system dynamics or varying levels of confidence. But I want everyone to have that level of confidence to dip their toe in the water, or at least know what to ask for. So today I'll cover a wee bit about me, a bit about NHS Wales, and I've broadly said there, this is the system that I'm talking about modelling. I'll then be talking about our project, which its focus was about facilitating timely discharge. So there is a complex discharge practice that is happening at the moment, and we're trying to unpick that. So that's our problem. System dynamics is the methodology, and then I'll try and wrap up. But I do have a few other projects that I can make reference to if people are interested in other work that we're involved in. So I just want to contextualise what I'd put in the brackets there. This is an illustration from two authors, Lorenz and Jost, from a number of years ago now, but I think it's really worth remembering. We've had a lot of talk on the chat so far today about system dynamics software, and that's one way about thinking about the tool, but don't forget that it's a methodology as well. It's a wee bit of a way of thinking. And what should inform our methodology is the problem and the system. So Sean was showing a nice illustration about how sometimes a particular problem and system requires SD or DES, there was that overlap, and at other times something's entirely strategic as a question or entirely operational as a question. But it's really important that we've got to bear in mind how it's those two things that inform it. But let's not forget about ourselves in this as well. So we've got our own personal filters, we all see our worlds in our own way, and we bring our own experience to it. So I hope that by everyone being here at this event, we're starting to add in an awareness of system dynamics that sits in that little sort of thought bubble, in that little light bulb of your toolkit of methods that you would at least consider. So at least let's put it in, you know, sort of resting on the edge of the toolkit, maybe still looking a bit shiny and new that we're a bit nervous about using, but let's include it as one of those options. So as a bit of a declaration for my sins, I do have an academic background, and as Sean mentioned, it's in discrete event simulation and system dynamics, but that's not just what I do anymore. So I was an operational researcher in health from a research side for over 18 years, and in the last 5 years I moved directly to work in NHS Wales. So I've got the privilege of chairing a group called the NHS Wales Modelling Collaborative. That's sort of the symbols that I put on everything, and that's because I generally work all across Wales, so across our 22 local authorities, our 7/8/9 health boards and strategic health authorities. I'm also running a research programme that's been funded by the Health Foundation. This project wasn't part of that, but again, happy to talk about some of that work. And I'm also the branch lead in NHS Wales for AFA. So again, some of those affiliations and some ways people might know me. So hopefully everyone knows where at Wales it is, what the lie of the land looks like. So even though we're a fairly small nation, we do actually have our health devolved, and we have health boards that are broken up across our local authorities. So as a piece of work, this was involved with the local authorities and the health boards, which meant that we had the 22 local authorities to deal with, and the RPBs, so the regional partnership boards that those local authorities then sit within, that link up with the health boards. So a real regional piece of work. So normally at this point in a presentation talking about right sizing, I defer to my lovely colleague Linda Chandler, who's since retired, and Linda's a nurse, and she always brings me back to why we're here and why we're doing this in health and care. And it's because it's all about the patients. So we know, and I've actually picked on you guys in NHS England, I'm afraid. I've pulled some of the reports and the statistics that you've got about your delayed discharges. So DTOC, delayed discharges of care. And so that one is our context around this. So why are we doing this with and for our patients? So a bit of the context. And then I come on to system dynamics, and Vanessa and Edwin kindly said that I could offer up my own definition. It's really nice to hear lots of the speakers this morning have each given their own different definitions of system dynamics. And I'm hoping it's a bit like being taught maths in school, where one teacher explains it in one way and it doesn't land with you, but I'm hoping that maybe all of us offering up our slightly different lenses on this, it'll help land it and there'll be something that really rings true. So for me, system dynamics is all about an approach to understanding non-linear behaviour of complex systems over time. It's characterised by those stocks and flows that have been spoken about lots already today. And it's all about those feedback loops and delays. So when we think about a system in health and care, we might think of a traditional, for example, a ED system where we've got reception, triage and treatment. And we might look at that and we might say that we would traditionally model that with discrete event simulation. But what if we've got a lot more question marks around this system? What if we're in a situation where we have lots of uncertainty about that inflow and that outflow? We also know that how we are treating patients has a knock-on impact about our capacity in triage, and therefore it might change some of our processes and our reactiveness in the immediacy of the situation. So quite an operational problem that I'm talking about here. Equally, how treatment is going and how it's performing might in turn inform how reception decide to actually process some of those patients coming in. And let's not forget that we could end up with loops outside of our control as well. So we might actually refer to this slightly messier situation as something that requires more of a systems thinking approach, where we can start exploring some of those relationships and testing our assumptions around it. So as mentioned earlier, system dynamics, we might be thinking that we're taking a bit more of a broad system view and we're trying to understand that dynamic complexity in there. And as I've said, about those stocks and flows, feedback and delays. So I've got a wee example for you, if that's all right. And actually it relates to some of what Hugo was talking about earlier about waiting lists. So it's just a silly textbook example, as it were. But this is my approach to system dynamics. So I start with a causal loop diagram. Again, this is something Sean mentioned in the chat earlier. So I like to visualize my system, first of all, as a causal loop diagram. So if I was thinking about the size of my waiting list, I would think about what would influence that size of my waiting list. So what would influence it is how many people I've currently got in hospital, my bed occupancy. Yeah, if I've got lots of people in hospital, I can't possibly bring more people in. But my bed occupancy would also be influenced by that referral rate. And unfortunately, we do also know that depending on how big that waiting list is, it can also have a negative impact on our referral rate. If, for example, clinicians are aware that there's a huge waiting list, they might advise people to go through other treatments rather than be referred in for a particular condition. Bed occupancy, well, that's an easy one, isn't it? We can quantify that with the number of hospital beds. But we also know that our waiting list is subject to political pressure, or in itself generates political pressure, which in turn can end up with little pockets of money for extra beds being generated, which helps us then because actually that increases our number of hospital beds, which in turn can help reduce our bed occupancy. So what we've got is two interacting balancing loops. But as press, etc., start to publicise the money that is now being released for extra beds, that in turn starts to influence the referral rate. So yes, I know it looks like I've just done a pretty diagram, okay, but it does actually have meaning and structure because we've done it with a clear purpose in that we're trying to understand what our waiting list will look like over time, and we've captured some of the core components that we believe are influencing this. And so we can actually start to build it up into that stock and flow model that's been spoken about earlier today. So we can start having those stocks that we're going to monitor as bathtubs over time, and we can then build it up to be a working model fully quantified. And what does that mean? It means that we can actually start getting those graphs over time. So our waiting list is that red line. Apologies for those who are colourblind, but that's the line that's peaking earliest on that time series. But we can see that waiting list peaking and building up, and then actually we've got this strange dynamic, haven't we, of that little step function that's happening. And that's purely because we're allowing the system to respond for more beds to be released, and that waiting list decreases, but actually overall it's trying to increase. So this is just a really simple little illustration. And it's not too far away from what I'm talking about with right sizing community services. Okay, So there was a few questions earlier about whether system dynamics was something that modelers should be doing and analysts should be doing, or whether it's something that those who are working in the improvement space. I would fully advocate those in the improvement space working on it. So this particular project was designed and led by our QPIMs, so Quality and Performance Improvement Managers within the NHS Wales delivery unit. So Linda Chandler, who's a nurse by background, and William Oliver, who is an operational manager by background. They had the vision for it, and I just had to try and get pen to paper and get the model up and working. We also had a few analysts dropping in and helping as well at the various points in time in the project. So the background to this project was all the way back in 2018. There was a national complex discharge review that was really focusing in on what does this mean for the patient. So time is the most important currency in healthcare: patient time, staff time, your time. And this responsibility that we all have and the opportunity to make a difference. So every time we have someone delayed in hospital, we are doing harm to those individuals, is the sad truth of it. So we've got evidence in our DATIX reports that shows that damage that we're doing to patients who are in the wrong place. Patients become distressed at being powerless, being disabled, as it were. I've forgotten the word. Not decompensated. My apologies. Sorry, it's gone from my head.
Deconditioned.
Thank you very much, Caroline. Deconditioned. Oh dear, terrible. But some awful representations here about patients not feeling powerless to the situation that they're in. So how can we support this? So obviously we're talking about demand and capacity here, isn't it? And you can see that we're then already starting to talk about right sizing. How can we make that capacity available out in our community services to discharge patients? So the very first phase of the work was that we went round to each of the local authorities, each of the RPBs, and first of all started exploring what data that they had available. And essentially we came up with 3 key mantras: knowing your numbers, putting the right intermediate care services in place, and measuring your outcomes. So sometimes the best conclusions are the ones that seem really obvious on reflection, aren't they? So it seems really obvious. And the methods that we were using here was just some very simple continuous time simulation. Okay, so not even a fancy discrete event model, just a nice simple simulation model that we were using. But we were then commissioned by Welsh Government to extend the work in order to take a more focused look. We wanted to actually specifically quantify the resource that was needed. And we had some really specific questions around, should we shift or should we do new investment? And again, this is something that's been spoken about at length earlier on in the day, about how sometimes there are unintended consequences when we make a change to the system, how things might get worse before they get better, and therefore a system dynamics approach that is looking at that full time period is really helpful. And our mission was then, or our objective was, to make clear recommendations about the need for robust and resourced data collection at each RPB and their ability to then do this modelling for themselves. So the pictures of the models that I've got are actually quite simple, and it's because we kept trying to model as simply as possible in order to just build up that picture and build that buy-in with our key stakeholders groups. So the outputs were all developed through a community of practice that the DU team facilitated. The DU team then developed the tools to the model and quantified the demand, and we gave individual feedback to each RPB. So each regional partnership board, in order to tell them what this all meant for them. So our model consisted of what was essentially 4 component parts. We were not just interested in modelling hospital and step down care. We wanted to also be able to capture that balance that has to be struck between the resourcing of step down community services and step up care. And in order to do this, we defined a population we were going to focus in on, and we made an understanding of where patients were at any point in time. So in our definitions, we believed that patients were either in one of 4 places. They were either in their place of usual residence, or they were in step-up care, or in hospital, or in step-down care. And underneath this model, we could then layer in much more detail. So essentially, we know that somebody who's admitted to hospital who is from the 65 and over population, we know that a large proportion end up going through a step-down care process. So that can include domiciliary care, reablement, through to care home. Some of them go direct to their usual residence, but of course those who've been through step down, the aim is that it's stepping down to get them home ultimately, so then we'd send them back to their usual residence. Equally, we know that some of those people in our population from our usual residence come direct into hospital, but if our step up care services are working effectively, we should actually have a good flow into step up that has a small proportion that are coming up into hospital, but actually manages to divert and have that hospital avoidance element going on. So a fairly simple model there where we've got all of those connected pieces. Okay. Now, I'm not a domiciliary or step down or D2RA or D2A expert. And so what we did is we drew upon the literature and we drew upon existing models. So Professor John Bolton from the Institute of Public Care in Oxford Brookes, he is well renowned in the area where he produces images such as this that's on screen. And we worked with Professor Bolton in order to understand what the situation was like in Wales and what our expectation should be around how our 65 and over population should be flowing out of hospital. So what we've got on screen is at the top there, per 1,000 people admitted to hospital, we would reasonably expect that between 500 and 700 of those, so 50 to 70%, should be discharged with no further action, discharged NFA. We should be seeing between 20 and all the way down to 5% going into very low level support. We should never be seeing somebody who has gone direct to a domiciliary support system or direct to a residential care system. In Wales, we would define that as bad practice. Somebody should actually be going through a reablement process prior to, so they should be going through intermediate care even for a short amount of time. Essentially, those two purple boxes that are more in the centre there, we would see that as that's bypassing the discharge to recover and assess pathway rather than actually allowing that patient to be well assessed. So we have that model of what we expect everything to look like, and then we can actually get into some of our data because we've actually got really good data on certain parts of that model. So we know how long our patients stay in hospital for. This is just an illustration to show you for our 65 and over cohort, we can see what the mean length of stay is for patients on a weekly basis, and that's the black or red dots. The red dots are just to denote if it was a special week that included a bank holiday there. Or we can also look at the median, which is the blue horizontal line that's got much less variation in it there. So we can look at what our length of stay looks like. But we wanted to populate that full John Bolton model. We wanted to be able to look at, well, where are patients going in Wales? How does it compare? And I know there's been discussion about data quality earlier today, and this was an example where the data quality was unfortunately quite poor, and a number of our RPBs actually said, do you know what, we need to go through this process again. We don't believe in our numbers, but I'll come on to how we still ploughed through with the modelling and we still quantified the models for them with the purpose of them being shown that art of the possible and the impact that can be had if they then actually fully quantify it for themselves. So the advantage of using a model such as this Professor John Bolton model is that we're able to actually look at that expectation versus reality, and we can use quite a simple model that just outputs graphs over time. So on these graphs, we've got the black dots with the grey lines in between. That's what our actuals are. And then if our system was working as our expectation would be of what a reasonable system would look like, that would be those coloured lines on those top two charts. So we can see for our residential care requests, we are currently sending a lot more people to residential care than we would expect reasonable to look like. And then equally for our reablement, we're sending substantially less. And we've included some SPC upper and lower bounds just to see whether or not we need a massive process change or not in order to explore that. So these are some outputs from a very simple version of the system dynamics model, okay, just to be able to then contextualize where we are versus where we should be. So that was our step down, but we've also got step up, and step up becomes a lot more difficult. So this is where that systems thinking methodology, thinking about engaging with key stakeholders, having that community of practice to start working with each of the RPBs and to understand, well, what does step up actually look like? Can we have that common model that we can all use, that we're all going to then aim to populate with data? And this is what they all came up with. So they all asked, they wanted this level of detail. So again, this is for our 65 and overs. So we've got it broken down by crisis response, home-based step-up care, step-up reablement, and then bed-based step-up care. They've also got a box for integrated teams, but you'll note that it's very small numbers in there. So that was their request because they acknowledged that their teams do that pooling of resources. But as we fed back to them, it's even better if we can actually understand what that pooled resource is actually doing in terms of those top 3 coloured boxes. Most stark about this as an output is the proportion of patients that we actually don't have an outcome from. So the lower half of this visualization is where we've got an outcome. So it's really important that we're knowing not just what our activity is, but then what's that onward implication for our patients as well. You know, that's not system dynamicist in me talking. That's just from a, you know, working in the NHS, we should absolutely be knowing what's happening to our patients afterwards. So the fact that we're only able to say for less than 25% of patients whether they were admitted back into hospital, whether they were discharged safely home, that's a poor proportion to have good knowledge about. We should know where they're going, because all of this helps us to then answer the question of where do those patients actually go and how much resource do we need to support that. So the final slide, oh sorry, Caroline.
No, I was about to say slide and then we'll have some questions.
Brilliant, no, of course, sorry Caroline.
No, loads coming up, I just didn't want to miss them.
So the last one I was just going to pick up about this was, well, what about the delays experience? So again, thinking in that same shape of that John Bolton model, just simply laying out the visuals to help socialize this idea of the model. So laying out what is known data over time, these are the delays being experienced in our system at the moment. I will open it up to questions. Sorry, Caroline.
No, not at all. That's fantastic. Just don't want to miss out on the questions that are coming up as we, because there's quite a lot already. So Martin said, just a question for you to have a think about is, system dynamic is one approach, and he wonders whether you could say anything about any of the other tools and approaches that you've used and whether those can work in collaboration with. And you heard this morning people talking about how we might use them in parallel with QI tools and techniques. So anything you can add on that would be fantastic, Jenny.
Oh, absolutely. I'll make reference to the QI tools and techniques first and foremost, in that we were working with quality and performance improvement managers throughout. So they were very much drawing on those tools throughout. So our community of practice was based around that structure and that engagement process that we were going through. When it comes to more technical side of tools, actually, I was always of the vision that we were going to be doing discrete event simulation modelling for key parts of this system. So the hospital, I'd envisaged that we'd be doing discrete event simulation for, and I'd aspired that we'd be able to get our step up and step down modelling to that level of granularity as well. The issue was around the sheer quality of the data, and every time you add more detail into a model, that expands out the number of parameters that you have to input. So rather than us having 100 parameters that we weren't sure of, we kept it simpler with a smaller number of parameters that we were then varying and emphasizing that uncertainty. But mixed methods modeling, absolutely appropriate here when we're then looking at translating what was strategic decisions into operational decisions. So how do we enact that?
Brilliant. And Martin's mentioned network analysis. Martin, I don't know whether you want to come in on that. Jenny's nodding that's something you've used.
Yeah, I mean, we're increasingly looking at other forms of approaching systems thinking. So I think it's important to make the distinction between systems thinking as a whole and systems dynamics as just a tool, one tool that we can use in that context. I think the other thing might be useful to stress is that there's a distinction often made in OR between sort of problem structuring or soft methods. And there's a whole host of those that generally get used in sort of problem definition and sizing, and then the quantitative tools or the modelling tools that we tend to use to sort of create the models and create the what ifs and so on. So I think that's another important distinction. But yeah, thanks, Jenny. Great talk.
No, thank you, Martin. I couldn't agree more. And to me, these are all tools in the toolkit that we need to be aware of. You know, the network analysis, whether we're talking about sort of hard operational research modelling or soft modelling, absolutely.
Brilliant, thank you. So before we allow you to press on, Jenny, could we just put one more question to you? Perhaps?
Of course you can.
So Bruce has asked how much of that, which we all get, don't we, that kind of the data is wrong reaction, that's kind of what we expect when we start, isn't it? Because the data is often wrong, but maybe useful anyway. But how much of that do you think was justified? Where did you go with kind of that in your...
Yeah, it's a really challenging one, isn't it? Where, how wrong is one question. Is it wrong or do we not like it? Is another one for us to bear in mind. Absolutely. I think it goes back to Peter Lacey's point earlier this morning, which is actually presenting that data back to people, having them actively engaging with it and use it, encourages people to start then improving their own data as well. So lots of the data that we were using in this was part of regular submissions that were going into, whether it be sort of Stats Wales, Welsh Government, etc. And therefore, when we then get someone say, well, that's not right, okay, that's worrying then, because these have been regularly reported for a number of years. And so, we need to unpick and understand. We didn't want it to be a point of challenge because we wanted ultimately people to take ownership of the models. So we didn't necessarily want to keep pushing, but what we did do was commit to have caveats on their presentations, still use their numbers and present what if in the context of these numbers that they weren't comfortable with. We did offer as well to make some adjustments that were more in line, but we also made sure that we were modelling both scenarios. So the first scenario was, here are your numbers, and the other, of course, was looking at this is what the expectation is as well.
Brilliant, thank you. That's fantastic, and a lot of love for those reflections in the chat. Thanks, Jenny.
It's a difficult conversation, though, isn't it?
It is a difficult conversation, and there's some interesting stuff around resistance, isn't there? And again, I'll pop some of that in the chat. But if we can allow you to continue, that would be fantastic. People are really enjoying your
fab. Oh, thank you, Caroline.
I
was worried I was going to have everyone snoozing off after their lunch, but maybe that's only when we do in-person ones and we've given them a good cheese board.
Yeah, people are very keen, so
So one of the other things we did in this project was that we didn't want to overwhelm people with the complexity of the model, but we also didn't want to shy away from the fact that it was modelling. So we were trying to present a lot of our outputs just visually laid out like the model. So the way I introduced you all to the model earlier was to have it as 4 boxes that were interconnected. And that's how we've then got these graphs over time up on screen now, in order to sort of illustrate how all of these piece together. Now, you'll note that these graphs look really boring compared to some of the graphics that we've seen from other people, and I'm afraid it's because I've done some illustrations to you rather than it being real data. Okay, so it's just static, but the other benefit is that those static lines, it becomes really easy then to observe when there's been a change in the system, because we can see how long it then takes for everything to work its way through. So the reality of the model, and apologies, I think the way I'm sharing the slide deck, it's made it look a little horrible. But this is the reality of what the system dynamics model looks like. So my colleague Debbie, who had never done system dynamics modelling before embarking on this project, she was a discrete event and agent-based simulation modeller, but it's her who'd managed to wrangle this together. But essentially she took what was our step-down model that was from Professor John Bolton and the step up model that was created in the community of practice. And we started by just having those working independently, a bit like again others have spoken about, and then joined them together. So it looks complicated, but honestly, it is actually, if I just go back one slide again, the way the interactions are working are exactly akin to what you're seeing on screen here. It was then also possible to start actually slicing each of the pots down to add more detail into that 65 and over age group so that we could have it by outcome as well. So for those who use Vensim, we were using subscripts in there in order to do that. Okay, so lots of data that's feeding in there, lots more potential to have more detail in there as well, but we stuck at this level. Okay, so one of the key questions that we were asked was, do we need to double run our services? And if so, how long for? So this is an example on screen that says, okay, well, let's now put that step change in. So we ran the model for a period of months. And we then said, let's instigate a change in the model. Let's see what the impact is. And this first visual is just focused on what the initial arrival is at each of these different parts of the model. So arrivals into hospital, arrivals into step down, arrivals back into their usual place of residence, and arrival into step up. But we're actually, oh, sorry, I'm going to skip forward a second because I've put the wrong slide in the wrong order, and my apologies. Oh no, oh, I've obviously hidden the slide, so my apologies all. I'll skip back. There we are. So sorry, it's not so easy to see on that slide. Oh, for goodness sake, I'm getting all tied up in knots here. But what we've got is that change then that's happening. And what we're able to do is monitor those graphs over time to see, well, how long does it actually take for that change to take place? What we were finding in the literature, because again, it's good practice for us to be looking in the literature as well for lessons here. But what we found from the literature was comments from academics and practitioners around how long it would actually take for a change to be instigated. And lots of projects were funded maybe for a year, and they said that after a year they could see some change, but they weren't too sure on what was going on. What we were finding is the very simplest of outputs. It would take over 6 months for any change to be felt. Now, bear in mind, we're doing this modelling just using these flat lines where it's really easy to see a change. And this is, of course, where we want to reach out to our improvement colleagues, because they've got lots in terms of measurement for improvement and complex evaluations and such like. And how do we detect that change then has been successful when we've got these big messy systems with lots and lots of movement in them. So I'll just plough on a little bit more just to cover off some of the recommendations, and I'll come back to the model a little bit more. Happy for people to jump in with questions on any of these recommendations. If you disagree, if you support, I'm really interested. So our mantra on our second stage of our right sizing community services work was unfortunately the same as the first recommendation or from the first phase, which was know your numbers, but we've added a caveat to it. We've said know your numbers and own them. And this was because we felt there was this big disjoint between those who knew what the service was doing and those who are maybe sat in a back room processing the numbers and submitting them. And it was clear that there wasn't this join up between those who submitted numbers and official figures and those who were running the service saying, yep, I accept that this is reflective of the system. Because what we all know is that then when we start adding that up for the whole of our nation, we start to hide all of that complexity that's going on in there. So we were finding that data just wasn't triangulating, that there were huge areas missing, that there was no single version of the truth, and most of the data was requiring manual trawling. So that was why we only took our model to a level of detail that meant that people could do that manual trawling, and it wasn't going to be a year's worth of effort from somebody. It was we were trying to find that nice balance. What we did notice that where the RPBs were developing dedicated teams, the data was improving. Their understanding about how this system working was hugely improving, and they've picked up and run with the tools that we've shared with them. But it goes back to that resource. So the problem we had is that the data is not replicable. We felt that none of the regions reliably knows exactly how many people are using those services. They weren't able to express their confidence in it. And each of them took to their regional partnership boards meetings to say that this now has to be a clear, a clear objective for them to make sure that they know this. So the recommendation was for them to identify teams in order to be doing this, to actively be involved in this, to make it everyone's business, that it should be a regular process. It should not be something that is only done as a result of someone coming in and offering support, and it should be a regular item on the agenda. Despite the barriers and the challenges that we had with the data, we were able to discuss with all of the RPBs in terms of, well, what does reasonable look like? One of the things I've not mentioned is that COVID was happening during all of this. So what we actually found was that there was a huge increase in the amount of step-up crisis response that was being done in order to try and prevent patients from, needing to access an emergency hospital attendance. So that allowed us to develop some benchmarks and to start exploring what might reasonable proportions actually look like. So again, it gives them something useful to look at. So we saw that step-up activity is substantially increased. And we saw versus the national benchmarking, so that's UK-wide national benchmarking, that it's 5 times more people that was happening than pre-COVID. So my question to you all, those of you working in England in this space, do you think your England data's got the same issue that we had? Is that a fair comparison? Are we really 5 times more in England than England? Oh, thank you for people's honesty in the sidebar there. That's really helpful. We've also seen step down activity reduce. So it's just over 1/3 of the reasonable expected number, which is, really quite shocking. So what does it tell us about what we're delivering and how we're delivering our services? So the work has aimed to illustrate the impact of adding additional resource into Step Up as one example that was asked to be looked at. But we also know through our community of practice that the ability to resource that is really, really challenging. And that's why our recommendation was that the policymakers and system leaders need to decide whether they're going to be shifting or adapting this scarce resource, or what their plan of action is in terms of adding to it. We've also noted that each RPB should use its modelled answers to the key 4 commissioning questions that we had, and they should be including this in their planning. We want plans with quantified numbers in, please. That's what we'd really love to see. So our 4 key questions that we were asking was, what additional or shifted capacity do we need in order to address the current bottlenecks? What do we need to get to what reasonable looks like? And then, does investing in more step up reduce demand for step down care? All of the intelligence that we had through the community of practice was yes, it does, but obviously there are limits to growth. There are limits to how much can be gained by that, because we can't stop everyone from going into hospital. Okay. And we also acknowledged in Wales that national work had to be undertaken at pace in order to develop integrated data collection. So the fact that it was not a reproducible process for people to go through. So what do we mean? The numbers are a little stark. To get to the reasonable expected levels, we were looking at an extra 452, roughly, extra places per week in intermediate care. You'll all have seen the adverts that are happening over the last few months about that, though. Note the stark difference, though, between care in the person's own home versus bedded. So it's normally easier to staff a bedded facility, much more difficult to staff those who are working in the community. But actually it's in the community that we do need that support. And it's not about vast increases in the number of care home places. It's actually those long-term packages of care, again, in the person's own home. So some of our key messages from the work was around the allocation of monies. We want to make sure that people are being clear on what their funding is intended to do when they receive additional monies to support it, and to use modelling in order to support that. We also emphasises that we need to make sure that we're not giving short-term pockets of funding, because that short-termism can be really challenging for people to actually manage that flow of staff. We need to make sure that we continue to support the RPBs. Again, this is something that's been referred to in a number of presentations of what's that community of support. So Vanessa, hugely supportive of this system dynamics community of practice that's hopefully going to come out of this, and hopefully you'll allow some of us from Wales to come and jump on in. And recruitment, of course, always a challenge. So we need that whole system transformation long haul, and we want to continue that engagement through a community of practice. So as I mentioned earlier, I was going to be talking about how big complex systems require system thinking. I hope you appreciate or you agree that I've covered that, but actually our model didn't need to be overly complicated in order to answer a lot of those questions. We had to be very careful to walk that tightrope of requisite detail, not put too much in there that meant that we buried all of the key levers that our decision makers might want to use in order to make a change to the system. It was all about socializing that dynamic hypothesis as well. So this is my unashamed advertising now, I'm afraid. So I want to say a huge thank you. I'm conscious there's loads in the chat and I've been really rude and not paused enough, have I, Caroline? So I'm very sorry. But I hope people might want to be involved, but throw loads of questions at me. Hopefully I've given enough time for that.